same as they always have. The front's the index where codes are looked up. In the back is the tabular with the further definitions of those codes. We always are told to look up in the index, go verify it in the tabular to make sure that you have your code to the highest level specificity. If you have coders on staff, that's a primary function for them. So if you're giving them the base code or giving them a written diagnosis, they would be then going in verifying that there are no additional digits or characters required for the code chosen. As far as correct coding, we'll kind of bounce over this slide a little bit. It's really more for the coders, but if you are doing your own coding, if you're using a book, like I just said, it's not any different than how you're coding today in ICD-10. If you're choosing your diagnosis codes directly from your EHR, then some of the testing needs to happen there to verify that if you're looking for a specific injury code, whether it's fractures or something else in your practice, that the EHR is either giving you questions to help answer the remainder digits of that code, or is laid out in a way where you can effectively find the specific code you're looking for. And what I mean by that is many EHRs are working and have created their ICD-10 so that when you pick a thing like an injury, so let's say we're picking a code for a traumatic femur fracture, the system will prompt you with a series of questions that will in effect code out the specific diagnosis code. So it'll ask things about the actual location of that fracture on the femur. It'll ask if it's displaced or not displaced. It'll ask if it's the right or the left femur. It may ask how the injury happened. And all of those questions and answers, when answered, will lead the system to pick the most specific diagnosis code it can, rather than just a generic femur fracture that may be unspecified or may not be at a specificity level that our payers are requiring. So, structure and format of an ICD-10 code. This is a sample ICD-10 code. They are up to 7 digits. The first 3 characters are what we call the base code or the category code. That first character will always be a letter. The second character will always be a number. And then characters 3 through 7 will be a mix of numbers and letters. There are some laterality markers. Those will always go in character 5, and they will always be the same. So, for example, the right side will always be 5th character 1, and the left side would always be 5th character 2. If the code has an option for a bilateral, that would always be 5th character 3. We have quite a few 7th character codes in orthopedics. Those help describe things like, what type of encounter is this? Is this the first encounter, a subsequent encounter, or an encounter for a side effect? It could define the type of healing that the fracture is experiencing. Is it a normal healing, delayed healing, non-union? And it will, or could also help classify what type of open fracture this is, or what degree of open fracture this is. And all of these categories must be in that 7th character spot. So where you see that kind of dummy red X, what that means is you may have a 5th 5-character code that requires a 7th character designation. And in order to get that 7th character in the right spot, we have to put a 6th character kind of dummy holder in place to push that last character out so that all of our claim systems and submissions will go out with that character in the right place. If we were to skip the placeholder X and put our 7th character in the 6th character spot, chances are it would make an invalid code and our claim would never leave the system. So let's talk a little bit more in depth about the codes within the musculoskeletal system. This will be our pathological fractures. Most of the codes in this section will have specifications for site and laterality. So our site would be obviously the bone, joint, or muscle that the condition occurs in. When conditions affect more than one area, so for example arthritis, there is a code for kind of multiple sites. So if you're treating the patient for arthritis or osteoarthritis in their right knee, you will use a code for that specific right knee. But if they're coming in today for a follow-up of more of a generalized arthritis treatment, then we can use a multiple sites code rather than having to list out multiple diagnosis codes for the joints and areas that this is affecting them. If there is no multiple sites code, then unfortunately we do have to code out each of the sites that the patient is currently experiencing and getting treatment for. When we talk about fractures, most of this is the same whether it is a traumatic versus a pathological fracture, difference being just the category or chapter that these codes reside in. So for fractures in ICD-10, we're always looking for definition, whether it's a displaced or non-displaced fracture, actually the location or the bone that's affected by the fracture, what type of fracture. And then episode of care is a big one that'll come up a couple times in this hour. Basically, is this the first time the patient's being seen by this physician for this problem, or is this a follow-up for this problem, or a sequela or side effect of this problem? And then for open versus closed fractures, we do have codes that define the open fractures further with that Castillo system. So having to know what degree of fracture that is for our open cases will help get the correct diagnosis. And then just for a quick glance on this slide, we have the Castillo type that we are looking for. Now, if this isn't listed, there is a unknown marker that we can use in the codes, but if there are traumatic fractures, open fractures being documented, it's not uncommon for us to already be seeing this in the documentation. So traumatic versus chronic conditions, like we mentioned, the musculoskeletal conditions, previous injury or trauma, recurrent conditions are captured here in the musculoskeletal chapter. Acute injuries or traumatic fractures are in the injury section, which is in chapter 19. And from a documentation standpoint, if the coders cannot tell what type of fracture this is, they should be coming back to you as the physicians to get that clarification into the note. We cannot just assume that it's a traumatic fracture if the note doesn't tell us. Usually we're finding out from the note, though, how the fracture happened, and that's usually a good indication for us of whether this was traumatic or not. So, 7th characters for fracture care. This is the kind of 7th character placeholder we talked about a few slides ago. The main ones that you're going to see throughout ICD-10 are A, D, and S. So A is for an initial encounter. What that means is the patient is receiving active treatment. That could be surgical treatment, an ER encounter, or evaluation and treatment by a new physician. So for example, if the patient was seen in the ER today for a fracture, they were splinted and told to follow up tomorrow with the orthopedic surgeon, and then tomorrow when that patient shows up in your clinic, that's still going to be an initial encounter because it's the first time you're seeing the patient for that injury, and that's going to determine their course of treatment. Now, when they come back in for routine follow-up of that fracture, that's where we move to 7th character D, subsequent encounter for fracture with routine healing. So after we're done with the active treatment, which would be, surgery, casting, etc., then we're going to move into subsequent encounters. 7th characters G, K, and P are when we're not healing routinely. So subsequent encounters with delayed healing, subsequent encounters with a non-union, and subsequent encounters with a malunion all have their own classifications, as does sequela or side effects. So if the patient is being seen after active treatment for a side effect from an initial injury. So a patient comes back in a few months later, now has a new complaint, and it's been tied back to the original injury. So this could be due to scar tissue, could be due to changes in anatomy, whatever it might be. If it's clearly defined as a side effect or sequela from that initial injury, then we'll code the initial injury with the 7th character S. Care for complications of surgical treatment. During the healing and recovery phases would be coded to our appropriate complication codes. So whatever that complication is would be separately coded. There's no seventh character to state this is a complication. So our initial episodes of care, like we said, we're actively treating. We're taking them to surgery the first time they're seen in the ER or the first time you're seeing them in the clinic for that fracture. Subsequent, every time we're seeing them after for routine healing, delayed healing, or non-union or malunion, we'll use those subsequent encounter codes. I believe the goal of using the subsequent encounter G, K, and P seventh characters would be for those patients who are going to require more work than a routine healing, and that would help support possibly additional office visits than the standard fracture care. And then you guys are all aware what the designations are between those types of healing. Moving into Chapter 19, which is our traumatic fractures. Similar to the musculoskeletal section, most of these codes are also going to have a seventh character extension. They are going to have up to 3 extensions. So most of our injuries will still follow the initial, subsequent, or sequela seventh character. Our fractures will follow the same seventh characters that we talked about for pathological fractures, so the subsequent with the various degrees of healing. We're going to assign separate codes for each injury unless there is a combination code provided. So if there are some fracture codes, certain bones that are commonly fractured at the same time, if one is fractured, it's common the other. So the tibia and fibula will have a combination code, but other bones may not. So it'll be getting used to which codes do and do not, and that's something that your coding staff can help kind of pull apart for you so that you know if you're looking up codes and say your EHR, when you should be pulling a joint code versus knowing you might have 2 or 3 individual codes for those specific injuries. We always code the most serious injury as a primary diagnosis. That's the same way that we're treating this now in ICD-9. And superficial injuries will always be coded only if they're kind of separate from the more severe injuries. So if I have a fracture, an open fracture, and a small abrasion next to that small fracture or due to that fracture, we wouldn't separately code it. But let's say I got in a car accident and have an open fracture of my arm and have a superficial wound on my leg that requires treatment, and those would be separately coded. Fractures of specific sites are coded individually, again, based off their category and their severity. If not identified as open or closed, the coders will always default to closed. And if not identified as displaced or not displaced, the default is always displaced. We'll be ranking fractures based off their severity from what we can detect from the operative report or office note. So initial encounters. During active treatment, traumatic fractures are coded with the appropriate seventh character. So you can see we have different seventh characters here for initial encounters for open fractures. So our standard initial encounter for a closed fracture is still seventh character A. And then B and C are used depending on the degree of the open fracture. So if that open fracture is not classified, then we would be using a generic, we'll be using B, open fracture not otherwise specified. The initial encounter code extensions should also be assigned for a patient who delayed seeking treatment for a fracture or non-union. So let's say I fell today and hurt my hip and put it off 3 or 4 days and then finally went to the doctor and was determined to have a hip fracture. We would still be coding today's visit as an initial encounter because I didn't go to the doctor or to the ER when the injury originally occurred. So it's still an initial encounter even though technically the injury happened multiple days ago. Complications of care. So again, based off of your documentation, the relationship between the